So I've been asked to talk to you guys about what I know about Ebola and what OSF is doing to get ready for a potential case that might show up in one of our healthcare facilities. Ebola is, as you probably know and have seen in the media hype, an awful disease. It is occurring in an outbreak in West Africa as we speak. And there are literally thousands of people who are sick and dying with it. In its extreme expression, once you get exposed and then infected and then sick unto death and then either die or survive, it's an awful disease to take care of. It's particularly unimaginable in its expression in Africa. Only in 3 countries, Sierra Leone, Liberia, and Guinea, right? Those 3 countries are involved with this outbreak. There have been outbreaks in Africa and in other countries of Ebola that have been going on since 1976 when it was first defined and named after a river in the Democratic Republic of Congo, the Ebola River. Typically, as has occurred in the Congo this year, in August, an outbreak pops up because folks who are in a subsistence environment have to hunt for food. And in this particular instance, a dutiful husband brought home a monkey to his wife to feed the kids. She butchered the animal and made stew. She got sick and died, he died, the family died. A couple of healthcare workers who made initial contact with the family also got the disease and died. Altogether, 49 people have died, and a total of about 70 or so have been infected. So it has a very high mortality rate in those environments. That outbreak started in late August, and currently there are no more cases showing up. It has been contained, partly because it's in a remote location. There's not a lot of traffic in and out. People don't get shipped out of there for care. And contacts have been identified and sequestered, and so as additional people got sick, they were able to be kept from other folks so that the disease wasn't transmitted. The virus is an ordinary sort of a virus. It's an enveloped virus. There are 2 basic kinds of viruses, with envelopes and without. That's a covering. The ones with envelopes are easy to kill, easier than viruses that don't have envelopes. And so this organism is easy to kill. Bleach, chlorine-based compounds, alcohol denatures the virus. So the hand rubs are great protection. The virus is spread, and this is based on 26, 27 years of experience with this virus. It's spread by contact with body fluids. It is not an airborne virus, and it is spread only if you have direct contact with secretions. Now, the unpleasant part of this virus is that when it's fully expressed, when it's fully involved, it replicates inside blood vessel cells and in other kinds of cells, and the cells begin to die and explode. And so they tend to not be adherent to each other, and fluid leaks into what's called the interstitium, third spacing we call that. People get edematous. They also tend to weep from their skin in the terminal stages. They can bleed. It is a disease that is manifested with severe gastroenteritis in its fullest expression of symptoms. And so diarrheal fluid and emesis fluid it can contain the virus. But those symptoms don't show up until late in the onset of the disease. The outbreak occurred in Africa, and I'll go to the OSF, One OSF website and click on the Ebola resources click and bring up the front page, which has some really informative things in it, particularly messages from Kevin Shepline and from Sister Judith Ann. But we'll focus our attention on the map. The outbreak occurred in Guinea, Sierra Leone, and Liberia, right where all these dots are. The junction of the three countries. There are characteristics about this experience that made it different than the pop-up in the Congo. Folks in this area have been engaged in open warfare, civil war, for the last 10 years. In fact, there are about 22 million people in those three countries. I think it's about 5 million that are in Guinea. And Guinea had 50 doctors before this outbreak started, because they'd left because of the Civil War. And so other characteristics that made this interesting or possible was that folks in that region, because of the war and because of the nature of the boundaries and the trails to commerce, to the marketplace, they move back and forth between those countries very readily. And then on top of that, there's a lot of people. As I said, 22 million total, as opposed to the Congo, which has wide open spaces, and the disease, because its reservoir is in the rainforest, in the jungle, it doesn't usually pop up in these locations, but it did this time. Make the situation worse, because of the effect on the medical care system, the resources are very limited, and so when this outbreak started in the late winter of this year, they missed the diagnosis. They thought they had cholera epidemic going on, and it wasn't until March, several months later, that they made the diagnosis of Ebola. So meantime, with this high transmission or movements back and forth, the disease had an opportunity to spread to a lot of different locations. And then they have a unique cultural experience around death. Their cultural tradition in this environment is that they take the body home and wash the body and wrap the body and hug the body. The time when the disease is most infectious and most able to be transmitted is immediately after death. And so it was kind of a perfect storm of meager care facilities, a compounding spread, and then the funeral practices. And then unfortunately, as is true in the United States, there's a lot of misunderstanding about what was happening. And so these folks lost confidence in the care that they could get to. And if you have time, you should Google the Ebola outbreak. Hell in the Hot Zone is a reference that you can Google. It's a series of photographic reporting of the actual conditions in some of these treatment environments, and you see folks on the floor in hazmat suits ministering to people. That's their hospital. They are mats on the floor. They don't even have hospital beds to care for these people. And so that's the current state of what's going on in West Africa. It is not an epidemic. It hasn't broken out of control, and is not involving large numbers of the population. There's about 20,000 people, they estimate right now, out of 22 million. It's an outbreak that's not well contained. And the international community has been late to the table to bring resources, and you know, finally we're starting to get resources brought in, but it's still a challenge to contain it. Still, it's not an epidemic, and World Health Organization and the CDC does not expect that it's going to spread like wildfire through the population. And that's partly because of the nature of the way the disease is transmitted. On the other hand, it can become endemic if they don't get control of it. And endemic means that it's always there, that it never gets totally extinguished and it's popping up here and popping up there. And under those circumstances, particularly if the number of people exponentially increases, it's going to be a substantial problem. Well, it already is an unimaginable public health emergency, world health emergency. But it's not a pandemic, and it's not going to turn into a widespread pandemic. Now, this is the point where I need to validate my qualifications to be able to talk to you about this.
This is a very rare strain of the Ebola virus. It produces mRNA, the deadliest of the stem loop structures. Oh, don't worry, it's not an airborne strain.
Excuse me, how long have you been studying the Ebola virus?
Well, I'm not actually a scientist, but I did stay at a Holiday Inn Express last night.
Stay smart. Stay at a Holiday Inn Express.
Now, this is not a funny issue. This is a very serious disease, and one that demands our respect and attention. I don't show the video for comic relief. I show it because there's a critical communication. He knocks it off. It is not an airborne disease. It is transmitted through contact with secretions. And so what's it mean to OSF and to us in our care environments? What it means to the United States is that there will be people returning from the West African countries who have been in contact with and exposed potentially to the virus. And they may present, and they may actually have the virus. When I first started doing these talks several days ago, the opportunity for that to happen was significantly higher than it is currently. As you've all seen, the federal government has stepped up with screening people coming back from those locations, and now they're all going to be connected to public health resources and watched very closely. So the occurrence that happened in Dallas, which is one of our opportunities, a similar event, is unlikely to occur at this point. It's much more likely that the introduction to our health system would come from a direct communication from the health department saying that they have been watching somebody and they need to be evaluated. So it's different now than it was, but the outcome or the experience in Dallas, which is a pop-up occurrence. It was not an outbreak of Ebola. It was a single person who presented with symptoms having recently traveled from one of those three countries. It's demonstrative in many respects because the man presented, Mr. Duncan presented to the emergency department and was evaluated, and I'm sure he had a typical big city emergency room experience, and he was there for several hours in order to get that evaluation done, and he was sent home. And during that period of time, there was no use of PPE. He was symptomatic. He had early onset of fever and didn't feel good. And so he had contact with all these folks, and then he went home to his family, to an apartment, and he was very closely relating to that family during the following couple of days until he got even sicker. Then he presented back to the emergency department, and this time they identified that he was at risk, immediately put him in PPE, and got him isolated and admitted. And so how many folks in all that experience got Ebola? 2 nurses got Ebola. All the rest of those people that had contact with him, and many of them very close contact, particularly the ones he was living with, none of those folks got Ebola. The 2 nurses that did, unfortunately, contact the disease were engaged in his care at the terminal stages of his care when he had profuse secretions. He also went through a respiratory arrest and had to be intubated and had dialysis, and so there was a lot of opportunity for exposure to body fluids under those circumstances. Now, the harsh reality is that caring for those people at that level of involvement is really a challenge. It requires a level of meticulous approach in teams with appropriate PPE equipment on and constant vigilance, along with spotting of the caregivers, monitoring the donning and doffing, new words to our vocabulary, of PPE, and really the opportunities for infection are, for exposure to the secretions are highest in the doffing, in the taking off of the PPE equipment. So it's a challenge. So what's OSF doing and what's our risk? The CDC is clear about what kind of preparations hospitals need to undertake. It's 3 things: detection, protection, and response. And so first off, detection. We don't want to engage in the care of anybody without having excluded the possibility, remote as it may be in our environments, of the fact that they may have traveled to one of those countries and or had direct contact with people that have the disease. Now, it's only those 3 countries. There's no more risk of a Congolese person, somebody from the Democratic Republic of Congo, bringing the disease into the United States than there is, or into one of our OSF facilities, than there is from Pittsburgh. Because that outbreak in Congo is contained, it has not spread, it will not spread. The only risk that we have is folks coming back from those 3 countries. In addition to that, the risk is manageable. And so once we detect those people, we have processes in place that'll scoot them into a private room so a further evaluation can be done. And in that process, engage the use of PPE, in particular to make certain that we address the needs of that individual patient and that we're careful about not creating panic in waiting rooms because of that behavior, because the risk is extremely low. And it's low from the standpoint of transmission as long as there are no body fluids present. Now, I still buy lottery tickets. I limit myself to the 400 million range, and about half the time I don't even check them because I know I'm not going to. It is theoretically possible that somebody could present to us with advanced symptoms, and it was a whole lot more possible a month ago than it is currently, because currently the screening processes that are in place getting back into the country are such that those folks are going to be identified and they're not going to present to us as a de novo presentation for care. So detection, protection, and I don't minimize the importance of the PPE use, particularly if the patient does have symptoms of diarrhea and vomiting and so forth. But the third is equally important, the third component, and that is response. We have developed the methodology for us to address these patients quickly, to mobilize teams to make sure that they get the attention that they need to get to further define the problem. Inherent in that is the mechanism so that if we have somebody who does seem to be at high risk for exposure because of where they've traveled and what they did while they were there in those countries, we immediately get in contact with the CDC, the Illinois or Michigan Department of Public Health first, and then the CDC gets involved, and we will get directions and oversight to our process to get those patients, particularly if they are people who might have a definite disease, transferred to a treatment facility at a different location outside of OSF. We do not expect that we will ever get to the circumstance where we need to be caring for these people in our hospitals. The condition of these patients in the fullest expression, that the full PPE requirements are so critical and so necessary, is really at the tail end of their disease. And the management of those patients does require a very sophisticated effort. So,
okay.
Question?
If I'm a caregiver and my patient has answered yes to one of the travel screening questions, and I'm the one who has to go in there and talk to them further, don't I want the highest level of PPE? Why don't we bust out the hazmat suits?
Well, it's a good question to ask, because everybody's seen the patient being the first patient on CNN being transferred back from Africa to Atlanta, and saw how they got him off the plane in the silver suits, and then there is this widespread, and this is the reason I show the Holiday Inn commercial, notion that somehow this disease is going to bust loose because it's highly virulent and airborne, and like smallpox, it's going to just go through the country like wildfire. There is zero evidence to say that. In fact, I have no personal concern whatsoever about being face-to-face and even having physical contact with somebody who's been there, who's having no symptoms at all or minimal symptoms. I'm going to use our first level of PPE because I know how to do it, and I'm confident that droplet and contact precautions is all that's necessary at that stage. And in fact, getting in and out of the hazmat suits is actually, if the patient did have secretions, it's actually more risk because of the contamination as you try to get out. If you've seen the doctor from CNN with the chocolate sauce on his gloves, you saw that it takes special attention and special effort. It just isn't warranted to have that level of protection. Now, if you're taking care of the very sick patient, yes, you need full PPE, but even then, the source of the PPE that the CDC is so clear about, or the key components, is simple barrier contact precautions. They did add covering all exposed skin, but the other two components of their recommendations were the more important parts. It's the spotter, the monitor, to help you get in and out, to watch you in the care process, and to keep you from accidentally contaminating yourself during that process. And then it's the preparedness. It's the rehearsal. It's the use of the tools. And so, since we're not going to end up with those patients, we are preparing for the eventuality that we might, with a special team that would respond and keep those patients away from our general hospital population and be cared for by a special team. But we don't think that'll ever happen, because We think there will be few cases, and those cases will be triaged and transferred to one of the facilities, either in Chicago or one of the national facilities, if we did happen to win the lottery and end up with that rare person who's actually going to get here. So what's the risk going forward? This outbreak in West Africa could get to involve hundreds of thousands of people before it gets controlled. And if it does, it's going to require that we volunteer to go help, that medical resources, caregivers from across the country are volunteering to be on site there in order to get control of it. And that will mean that more people will be coming back. And we may see pop-ups, just like the doctor in New York that was treated, in my view, entirely appropriately. The public health department had the relationship with him as he came back. He self-contained himself. The minute he had fever, the prodrome to the point where he would become infectious, he blew the whistle and he got the care that he needed. And in my view, this is going to be a beautiful demonstration for the country that widespread occurrences are not going to be popping up, just like happened in Dallas. Now, you can't fault people for being anxious and concerned and afraid of this virus because of the TV hype. You know, Dustin Hoffman and his, I've forgotten who the female co-star that was, Hot Zone it was called, or Outbreak it was called. And even the commercial that I showed you, you know, they're in a containment unit and looking through a microscope, which is crazy in the first place because you can't see Ebola virus looking through a microscope. But the hype is that this virus is you know, just awful. It's the calamity of calamities, and it will not happen that way. Pop-ups can occur, and unfortunately, healthcare workers are at risk. So we have the steps that we've taken, the 3 steps, are key to keeping us safe. Other questions?
What is the turnaround time to do the test to know if there's Ebola?
Okay. The blood test. The blood test can only be done by the initiation of the Illinois Department of Public Health. And just this weekend, they got approval as one of 6 states who have the capability of doing the test on site in their lab in Chicago. And so it would be ours. Previously and currently also, half of the specimen has to be tested there and the other half sent to the CDC lab for confirmation. That confirmation may take longer. And previously it was 48 hours, but I believe that time is way shortened. Most importantly, the decision-making about the patient doesn't require the blood test to confirm the diagnosis. The travel history, the exposure history, and the symptoms identify what the government has called a PUI, a person under investigation, who needs to have the blood test done. But the PUI needs to be treated as if they actually have the disease. And then there's another category called a PLD, a patient with likely disease. And so this doctor was labeled as a patient with likely disease and was put in isolation and in a containment environment. There's a third category, patient with confirmed disease, and that's the person who's had the test and confirmed the diagnosis and often has significant symptoms. People survive this disease in good care. Many, many people are dying in West Africa because they don't have IVs. They get dehydrated and in a tailspin, and they can't get out of it. And so, while it's a disease that is a big-time virus and can overwhelm the individual, even with the best of care, like Mr. Duncan got, The mortality rate in the United States is probably in the 20% range, not in the 50 or 70% range that's occurring in Africa. So. Other questions?
Since the only people that have been positive for it have been healthcare workers, are we going to see less people going to help the people in Africa?
I think, yeah, I think the concern about exposure is in every healthcare worker's mind when they go there. But I really believe the biggest deterrent is going to be the inappropriate response of the governors of New York and New Jersey and Illinois to quarantine under law and restrict, as happened over the weekend. And I noted that they released that nurse this morning because I think they realized they had misinterpreted the scientific evidence and were taking steps that were excessive. So. I have one more thing if there's no other questions, and that is, should I tell you my Ebola joke?
Yes, please.
Nah, you won't get it. That's the joke. No, you won't get it. Not frivolous, serious, very serious. You're not going to get Ebola. The steps we've taken and the vigilance with which we're going to approach people once we've detected that they might have it, and the fact that we're not going to be caring for those extremely ill folks is the most important message. That and that it's not airborne. So, thank you.